Thank you very much. I am Dr. Baye from Santo Domingo, and I would like to share in the next few minutes our experience with the pre-sort flow microshunt in Santo Domingo. We are paid consultants for the InFocus and Santen company, and we have been conducting this study for the last 10 years in Santo Domingo in collaboration with the Bascom Palmberg Eye Institute. It is all about the pre-sort flow microshunt. In the classification of mixed devices, it falls under the category of bleb-dependent devices to be differentiated from those that are bleb-independent. It is an arrow-shaped tube with a lumen of 70 microns and a length of 8.5 millimeters, placed at 3 millimeters from the limbus, connecting the anterior chamber with the subtenon space. So it is a bleb-forming device. Preferably, it is placed in the supratemporal region using 0.2 to 0.4 milligrams percent of mitomycin C and the 10-Pankov technique. You need to avoid viscoelastic, where it will actually block the lumen of the tube. And we show here how, after marking the sclera, a 27-gauge needle is advanced into the anterior chamber. The fins are anchored in the sclera, and we compulsively verify flow of fluid through the tube as it is seen emanating from the lumen of the tube and absorbed by the Wexel sponge. In our preliminary study at 5 years, we had an average pressure of 12.3 millimeters. And at first this was questioned, and the question mainly was, can these results be reproduced in other places? And the answer is yes, thanks to the collaborative studies between Europe, Canada, and the Dominican Republic. The device has now been shown to work in all these areas with an average IOP at 2 years at 13.8 millimeters of mercury. Will this reduce the number of glaucoma meds? And the answer is yes, going from 2.2 to 0.5 medications at 2 years. And if we were to compare it to the Zen, and this was done by Dr. Lottie in the Netherlands, then the Zen is less likely to succeed when compared to the preserved flow. And does the concentration of the mitomycin C really matter? And the answer is yes. When we use the 0.4 milligrams percent, we're more likely to have a successful bleb and to use less medications than when we use the 0.2 milligrams percent concentration. How is the FDA study going? And the answer to this is better given by Dr. Palmberg, that we do know that there are more cases of hypotony in the trabeculectomy group as compared to the preserved flow group using 0.2 milligrams percent mitomycin C. So we foresee that the preserved flow will replace the trabeculectomy as from its golden throne in the years to come. Thank you.
So we've talked about the complications that you have with trabeculectomy in tubes, and as being a reason that we would like a different way of doing the surgery. And these microshunts solve some of the problems. They are more predictable for the pressure gradient across the sclera, and therefore less risk of hypotony, which has now been, and bleb leak because of a posterior bleb. And that has now been shown in the randomized clinical trial out to 2 years. There's about half as much cataract because you don't need a peripheral iridectomy. You're not keeping the fluid from nourishing the lens in its normal way, passing circumferentially around it. By the fluid going through an iridectomy, you don't have all that normal flow to nourish the lens and carry away its waste. Less refractive change because there's no scleral flap or sutures, which in some trabeculectomy cases where the pressure is quite low, you can have flap sutures create quite a bit of astigmatism. There, versus the tubes, there are less risk of corneal problems. It's a much smaller tube. There is no plate. You don't have the diplopia problems. And the tube exposure problems, I think there's only been one case out of about 1,000 that I know of for sure where a tube got exposed from the primary surgery. If it's been revised in some way, then there are a couple more that eventually got exposed. But not as much problem at all. And it's very important though, all of these, the Zen, the microshunt, any other tube, have to be coming out of the sclera behind where the upper eyelid moves. And Felix Gil Carrasco in Mexico City at Asociación para Evitar la Ceguera is the one who showed that in his 9,000 Ahmed cases, where they didn't have an eye bank and didn't have patch grafts, but they were able to use this long tunnel technique. And this has now been adopted in the United States and without using patch grafts by a lot of the leading glaucoma surgeons who do a lot of surgery. There's some people like Steve Getty, who is a very, very cautious person, who not only does the long tunnel, but also puts a patch graft on as well, trying to make sure there's no tube exposure from the motion of the lid. Now, the motion of the lid will melt the patch grafts. And sometimes you just end up with the tube, and then on each side of it, some of the patch graft material as a flat, relatively flat surface. But in other cases, by 5 years, they had 5% tube exposures. So that patch grafts are not the answer. Long tunnel is to reducing it a great deal. Whether you add a patch graft behind that or not, is we don't know if it actually has any further value. And they are a simpler operation with less postoperative care, and they probably take less training than a whole fellowship, which is needed to understand how to make a scleral flap and when to cut stitches and when not. But the handling of the conjunctiva and tenons is actually more demanding than on a trabeculectomy. Now, Francisco Pontes, who unfortunately has passed away, had the question, can a small diameter tube substitute for the scleral flap in filtering surgery? And he worked with the company Infocus, which has now been bought by Santon, and they developed a tube. The pressure gradient across the tube is proportional to the length of the tube, which is 8.5 millimeters long for the Infocus, 6 for the Aquisys Zen. It's now bought by Allergan, so Aquisys doesn't exist. It's proportional to the viscosity of the solution, but aqueous has a viscosity in normal conditions that's very much like water. However, if you have any viscoelastic in the eye, that would make a difference. And that's not so much of a problem with the Zen, which is hydrophilic, but the hydrophobic pressor flow or microshunt needs to be primed and not have viscoelastic, because that can block it. And it's proportional to the flow rate, which is about 2 to 2.5 microliters per minute in the morning and about 1.5 at night. Now, that's been very carefully studied with fluorophotometry, and it's remarkably similar, the flow rate of aqueous, if an eye has not had damage to the ciliary body by cyclodestructive procedures. This is one of the things I worry about if people have had cyclodestructive procedures, even this mini cyclodestructive procedure on the outside, and then you put any kind of a tube in. If you've really cut down on the flow, you could get hypotony that otherwise is avoided by using these devices. And it's inversely proportional to the internal diameter, which is a very appropriate 70 microns for the microshunt, and a really too small 45 microns for the Zen. They really didn't want any hypotony, but unfortunately, this really creates too much resistance with the Zen. They're coming out with a 63 micron microshunt that they're selling, I think, in Canada, which would be more appropriate to give a pressure gradient that you really want is about 4 to 6 across the sclera. So this device is made of sieves, and this material has been used in over 1 million heart shunts by this guy, Leonard Pinchek, who invented sieves. And he also invented the balloon catheter for cardiac surgery, which involved sieves and has been used in over 1 million patients and has been used for more than a decade. He just won what's the equivalent of the Nobel Prize for engineering for this, for the balloon catheter in the sieves material in 2019. And $500,000 and obviously a great honor. Other people who've won this are like the people who invented the MRI or the CAT scan. So it's really a marvelous material. These are the people who worked on it. Jean-Marie Perel, the guy who developed modern vitrectomy instruments, and Francisco Pontes. And then these are people who worked with the company. and one who was absolutely instrumental in the early testing of this. And he's probably the best ophthalmologist in the whole world. He took 3 fellowships at Bascom Palmer, pediatric ophthalmology, neuro-ophthalmology, vitreoretinal surgery, and went back and founded a very wonderful residency program in the Dominican Republic that's world class. And Isabelle Reese in France, who was also doing cases with in the early testing of the device. So it's non-degradable material. As I mentioned, it's been used and it's very flexible. It has these little fins to hold it in place. Now the Zen is a cross-linked collagen that is dry. It's like a noodle, and when it gets wet, it swells, and that's what holds it in place and through the needle track in the eye. But this requires the fin. This is the material. Here's the structure. As you see, there are no reactive groups, no chemically reactive groups here. It's polystyrene. And as you know, polystyrene just doesn't degrade. So if you put this material underneath the conjunctiva of a rabbit and you put silicone that's in the barbell and Ahmed, put them under the conjunctiva, you end up getting collagen formation and myofibroblasts. You stimulate new blood vessels and division of cells around silicone. But around the sibs, that does not happen. You get a little bit of collagen produced because of the physical pushing against the tissue, but you get no new fibroblasts from contact with the material itself. And you don't get any new blood vessels coming into the area. So it is the most inert, non-reactive tissue. But you're still going to have reaction from the aqueous flowing into a tissue because aqueous has some growth factors. And when they examined this in the laboratory, Stanley DeVoby, our pathologist, eye pathologist, showed that around the silicone, you get a 200 micron capsule with some new blood vessels, but with the SIBS material, just a little bit 20 micron capsule of collagen. So we expected very little reactivity, but there's one thing we didn't think about that I'll bring up. And you do need mitomycin, and you need a good dose of mitomycin because I actually had to convince both of these companies when I was working with them that their devices wouldn't work well, wouldn't work optimally without mitomycin. The Zen people really didn't want to do it, but they were having trouble giving their training. And I said, well, let's call one Baye. I bet we could get some patients in and do it in a class operating room. And in fact, we had 30 patients come in, and all 10 investigators for their FDA trial were trained in 10 days. But we insisted on using mitomycin, which we injected 30 micrograms of mitomycin on those cases. But here's the micro shunt, which they want to call pressor flow now. And Juan has shown you that you make this needle track, or they have a little needle knife, they'll do that. And then you're going to put in the device. And as you can see, it's going to drain. It's about a couple, you have a couple of millimeters in the anterior chamber, 2 or 3 in the sclera. It's going to drain another 3 millimeters. In other words, the drainage is taking place 6 millimeters behind the limbus. So it's a very posterior bleb, less likely to cause any kind of discomfort. But it must be placed under an intact Tenon's capsule. That has turned out to be very important. And very important, now that they have that slit knife that you put the device in, you've got to check the pressure equilibrium flow. You have to both prime it and check the pressure equilibrium with the microshunt. And the reason for that is this new slit knife, it is possible to shove the fins in too far so that they go into the more anterior needle track wide part and pinch the tube, so that you could have pressures that are, instead of being 7, 8, 9 the first day after surgery, are 15 or 17. If that happens, you're pinching the tube. And one really at that point should open the conjunctiva and pull it back out. But best is during surgery. Check the pressure is no more than 4 to 6 millimeters of mercury before you close the conjunctiva tenons. And if it is higher, pull back a little bit on the device so it's not, the fins aren't pinching the tube. And that solves the problem. And it doesn't make it leak around the tube. It just means that the little bit wider part, little triangular area under the sclera that where the fins are supposed to fit, that it's properly there and not further forward into the needle track part. Well, as I say, Juan's pressures were about 11 at 3 years in his first cases and have been about 12 millimeters of mercury in the hands of Ike Ahmed and other people who've done hundreds of cases. The dose of mitomycin makes a great deal of difference, going from 0.2 to 0.4 in the cases in France resulted in a pressure that was 1.5 millimeters lower, and very importantly, half as much medication needed to be added back at 0.4 versus 0.9. The blebs that you see are not too high. They're very diffuse when you've applied the mitomycin. We had one case where there was no visible bleb, but the pressure was 12, down from the high 20s. And there must be some drainage that's going back through Tenon's capsule and the lymphatics in the orbit, we think, in some cases. But the keys to success, and this turns out to be true for both the microshunt and the gel, it has to be under an intact Tenon sheet. I showed you how I make a relaxing incision to get behind, and Ike Ahmed does that, and Juan Baye does that. And if you don't use that relaxing incision and get under tenons, lift it up off the sclera, slide your scissors across in that potential space, pull back down towards the limbus, and cut back towards the limbus. If you just make a little conjunctival flap and your scissors are in there spreading and cutting inside tenons, you will fillet tenons into shredded tissue, and you won't have an intact sheet to maintain that potential space under tenons. What happens in about 10 to 15% of cases with the microshunt and 30%, up to 30% of cases with the Zen, is the motion of the tip of the tube on the outside of the eye. If it's inside tenons instead of under an intact tenons, that rubbing produces stimulation of fibroblasts, just like my compression stitches in a bleb can mechanically stimulate fibroblasts to, even though they're mitomycin treated, they don't divide, but they do make collagen, and they can make a cap over the tip. And needling doesn't really seem to solve that problem very well. In the case of the Zen, people found instead of needling, it's much better to lift up the conjunctiva, stuff the tube back under the tenons, and close. And in the case of the microshunt, just have an intact tenons in the first place. And now at the Academy last year, I heard several people say they're no longer putting the Zen in from the inside. They're putting it in from the outside, opening conjunctiva, putting on the mitomycin or injecting it to make sure that they're getting under an intact layer of tenons so the tip of the tube is not rubbing inside. And as they say, you have to prime the microshunt and use a 0.4 for 3 minutes of mitomycin. You want to use more mitomycin. You're not having blood problems. You're not going to have hypotony problems. So you can use a bigger dose, which is not only important in the first 2 years, very important, as I showed you with my data, to having pressure control for 10 years. If you want to have 60, 70% of your trabs work for 10 years, you need about 0.4 for 3 to 5 minutes. And if you've applied the mitomycin the way Peng-Pa does, and you've opened and closed tenons intact, you're just not having the bleb problems of infections and leaks that were used to be associated with a high dose of mitomycin. So you can have the efficacy and have the safety. It's taken us quite a while to understand that. And it all has, much of it has to do with the management of Tenon's capsule. Well, here's the Aquasys folks, the guy who invented it, the guy who invented the inserter, and the CEO who put the company together. And this very interesting paper talks about the drainage back through lymphatics in the orbit. With the blebs we used to make, the fluid really did come up through the conjunctiva quite a bit. And we got into some trouble, but you could see fluid coming up through the conjunctiva. With these other devices, and with an intact tenons, the fluid is much more draining back through the lymphatics in the orbit and not coming through a thin and, I would have to say, vulnerable bleb coming up to the surface as much. You don't see the bleb sweating as much if you put fluorescein on it with the way we're using these devices. So I'm going to skip a little through this. Here's the material, and it swells when you put it in. And they used to put it in from the inside, but it's really better to put it outside. They had a very high needling rate. They tried it without mitomycin. It failed an FDA trial. They did it with mitomycin. I was advising them, I said, look, don't give up. Just use mitomycin, but open the conjunctiva and put it on. And it did barely pass. But these operations, these new operations, and trabeculectomy itself, are meant for primary glaucoma surgery, not so much repeat. There, I think the barbelt and the Ahmed are more effective. And but with Ike Ahmed, he had much better success. He got about 13 pressure, a little higher than with the microshunt, because the pressure gradient for this is about 7.5 millimeters of mercury instead of 4 to 6. It's really too much, and they should have the larger, little bit larger diameter too. And then people have been putting the Zen in from the outside,
from the pre-marked spot with the Fechner forceps,
so that it's on top of Tenon's capsule until you get near the limbus.
The injector will then engage the sclera 3 millimeters posterior to the limbus and is passed through the interscleral space with countertraction from a Vera hook until it enters the anterior chamber, dimpling down slightly to enter a slightly steeper angle for greater clearance from the cornea. The Zen 45 is released from the injector in the usual fashion. This patient is a 56-year-old African-American male, high myope, with POAG and severe field loss, who was referred to me from a nearby VA hospital, having already had a trab and Ahmed implant in his other eye with disappointing results. He was sent specifically with a request to try something other than a trab or tube to control his disease. And so we are trying a Zen 45 here as an alternative.
Okay, so that is a way you can put it in. The problem is with only conjunctiva over the Zen, they can get exposed. We're going to have to see what a problem that is over time. We have seen 3 cases of exposed tubes with the Zen where it's been put in from the outside coming through our emergency room, and I think 1 or 2 of them had endophthalmitis. So I'd rather have the tubes underneath an intact Tenon's capsule. But these devices are certainly more effective than the other MIGs that you will hear about tomorrow. Dr. Vives is going to talk about them, the ones that work in the angle and do not have blebs. And again, what are we trying to do? We're with the MIGs, you usually get pressures here. That might be good for 70% of patients with glaucoma, but if you really want a pressure down around 12, then the microshunt and maybe the Zen, if they make a little bigger diameter, would be capable of achieving those kinds of goals. And particularly in people with very advanced damage, the trabeculectomy or the microshunt are, with a big dose of mitomycin, are probably going to be good. And as we've shown you, you actually can get some return. And we talked about that yesterday. So we'll leave that one. Are there any questions about these devices?
Yes, doctor.
Yes.
When you talked about the cyclodestructive procedures, does that include, I know that micropulse laser doesn't destroy per se the cells, but they do affect the production of the aqueous humor. So
yes, and so it's going to be dangerous to put a barbell into an eye, and maybe these microshunts. Let's just say you're going to have more risk of hypotony. So that I would do these before. I'm not as impressed with the pulse as other people are. I know it's really strange. Some people say, oh, it's wonderful. And some people say it hardly works at all. There are probably some things about technique that matter. But I don't want to destroy tissue until I have tried first to get a proper filtering operation going. I want that aqueous to nourish the lens, nourish the corneal endothelium. And I don't like destroying tissue as a way of getting things controlled. You know, as after you've done a trab, it failed, you did a tube, it failed, but you're close, doing a cyclodestructive procedure to now get down the rest of the way, that makes a lot of sense to me. Dr. Lee in my place loves doing primary cyclodestructive procedures, and I'm really concerned to see what the early results actually look pretty good, but I am concerned to what's going to happen in 5 or 10 years from destroying tissue. So, you know, I would be cautious about any of those things compared to things you can do to improve aqueous flow.
Okay.
I'm just basing this on having done cyclodestructive procedures for 40 years and finding the long-term results very disappointing, not only for pressure control, but for just the corneal endothelium falling apart, not being fed as well. We'll see. You know, are these newer techniques really different? We'll find out. In the meantime, I have operations that I know work 10, 20 years. I'm sticking with those until people can show me 5 or 10 year results that are as effective and as safe. That will be critical.
Sure.
Let me go on to show you something else that's important. If you're wondering if somebody has hypotony maculopathy, sometimes you need, this is a patient where neither the glaucoma specialist nor a retina consultant could see anything wrong with the macula. Pressure was 2, the vision was down, and they wondered if it had been snuff out or what was going on, and they did. This was the other eye, and then the eye that had the low vision had folds, chorioretinal folds that really were only detectable with OCT. So OCT is really important to try to distinguish this. If you can't see the folds and the vision is down, to decide, well, do I need to do that 2 sets of stitches operation to get the vision back up? Doing an OCT sometimes is going to answer where you can't really see those folds well enough. And some blonde funduses in Caucasians, it's a lot harder to see the folds. And then another case, and this is at our Bascom Palmer every year has a meeting in Spanish and English in the fall. It will be hybrid, I think hybrid this year, or certainly in person in the week after the Academy in Miami. And every year we try to present cases that our visiting glaucoma person talks about. And this year it's Felipe Medeiros, who's from Brazil originally and now at Duke, and it was in San Diego, who's going to be talking about monitoring visual fields and OCT. And let's just show you this case, which was presented. I saw
and
this
now
patient.
we present the X-Files, cases that teach. We're doing this in honor of our late colleague Francisco Fontes, who introduced these cases to the Corso. We call this case a surprising intervention. A 20-year-old female presented to the Bascom Palmer Eye Institute one day after a bungee cord injury to her left eye. Her chief complaint was pain and blurred vision in the left eye, though her visual acuity was 20/25. Slit lamp examination revealed normal pupil responses, 17 millimeters of mercury pressures, and visual fields that were full to finger counting. Slit lamp examination revealed a temporal subconjunctival hemorrhage in the left eye, but no scleral laceration. In the anterior chamber in the left eye, there were 3+ cells perhaps red cells, and some pigment, but no gross hyphema. There was an angle recession on gonioscopy, gently done with a Zeiss 4 mirror and a water bridge to the cornea. The iris and lens appeared normal. On fundus examination, there was a suspicion of a choroidal rupture in the macular papular region. An optical coherence tomography was performed that indeed showed the choroidal rupture as it indicated with the blue arrows. The intraocular pressure began to rise 14 days after the injury and rose to 35 millimeters of mercury. At that time, the vision in the left eye remained 20/25, and although there was an initial response to medical therapy, the pressure then remained 31 millimeters of mercury on maximum topical meds and acetazolamide. At 45 days after injury, a trabeculectomy was performed in the left eye with a tunnel filtering procedure, as we have described, and with the use of 60 micrograms of injected mitomycin. On the first post-op day, the vision was 20/80, and the pressure initially 24 millimeters of mercury with a low bleb, and with very gentle massage, the bleb elevated and the pressure came down to 18. By post-op day 6, the vision was still 20/80, the pressure 9, and the patient reported distorted vision. What would you do about a decrease in vision with metamorphopsia in the early postoperative period? Monitor the vision and pressure, expecting it will improve, or doing a dilated fundus exam looking for hypotony maculopathy. That was done, and there were no folds. And it was decided to get an OCT to better assess the retina. Second-year resident Stephen Russell got a macular OCT, and there was no hypotony maculopathy nor CME, but there was a choroidal neovascular membrane at the spot of choroidal rupture, and there was leakage of fluid to the fovea. After consultation with the retina service, intravitreal Avastin was given. The vision steadily improved to 20/40 in 2 weeks with a pressure of 8, and to 20/20 in 5 weeks with a pressure of 9. And as you can see, with a very functional filtering bleb. Visual fields showed, after enough time for recovery, that there was optic nerve and retinal decrease in function with a mean deviation of -8 decibels in the left eye and a normal field in the right eye. And the choroidal rupture was now more readily seen. The clinical picture of a choroidal hemorrhage sometimes is difficult to tell because subretinal hemorrhage could obscure the rupture early on, and later it's seen as a curvilinear or crescent-shaped line. Fibrovascular activity leads to a scar in the ruptured area, and atrophy and thinning of the retina may occur. The development of a choroidal neovascular membrane after a choroidal rupture was described in Dr. Gass's atlas in 1970. Such membranes can occur in 10% of eyes with a choroidal rupture, with risk factors of longer ruptures, macular ruptures, and older age, although this patient was young. And 80% of patients who do it are going to do it within the first year. So the key points: patients with a history of blunt ocular trauma need to be monitored for glaucoma for the rest of their lives. Even if they don't have it shortly after the injury, 10% may develop it late because of sliding of corneal endothelial cells over the denuded trabecular beams in the site of injury, as described by David Campbell. And you have to monitor the other eye too. And in fact, in this patient, it was seen to rise to 27 millimeters of mercury on no therapy. And 1/3 of patients with angle recession glaucoma will be found to have ocular hypertension in the other eye, either at the time the first eye is injured or after a few years. This is certainly much higher than the usual rate of ocular hypertension and suggests that eyes that develop glaucoma after an injury perhaps were destined to have elevated intraocular pressure in the future and were just advanced along by the injury. So you need to monitor closely when there's a choroidal rupture for the development of choroidal neovascular membrane in eyes with choroidal rupture, especially within the first year. And consider alternative causes of vision loss in patients in the postoperative period. It would have been easy to imagine that this patient's vision was down on the basis of hypotony maculopathy, but it wasn't the problem. Don't blame the bleb. Thank you.
So that very instructive result where my second year resident figured out what was going on and I hadn't. Couple of other things here quickly. Unsolved problems in glaucoma. And these are things to think about. These are things we don't understand yet. And we think about them. One of them is what causes the corneal endothelium in the ice syndrome to go crazy and grow down over the angle to cause glaucoma, to grow over the surface of the iris and contract, which can cause these holes of essential iris atrophy. Chandler's syndrome, where you just have a little more edematous cornea, but otherwise looks fine, or even this bizarre Cogan-Reese iris nevus syndrome, where the normal iris are these little bumps, and the abnormal part is the corneal endothelial tissue that's gone haywire and multiplied, that is lining the surface of the iris now and contracted, throwing up these bumps. Really bizarre disease, but they're all the same. They all have abnormal corneal endothelial cells, and they're always unilateral. David Campbell figured out the pathology on this and united these three diseases as one. Jorge Alvarado at the University of California found herpes simplex in these cases, but we did 6 cases at the University of Miami with a positive standard control, and we could not find herpes simplex DNA in the specimens that were taken, an iris specimen that included an area involved, or on the cornea in such an eye. So we don't know. We still don't know what causes this. And what about Fuchs heterochromic iridocyclitis? Here's an inflammation that doesn't form anterior synechia or posterior synechia. That's bizarre. And so you don't need steroids to treat this to prevent synechia because they don't form and they only elevate the pressure more and cause the cataract to develop. So they're contraindicated. Also in Fuchs, you can get neovascularization of the angle, a very mild neovascularization that when you do a paracentesis, it bleeds on the other side of the eye, of the anterior chamber, very fragile little vessels, but they never close the angle the way other forms of neovascularization do. So why can you have a bizarre kind of neovascularization? Why can you have an inflammation that doesn't cause synechia? Just don't understand it. And there is evidence that a rumella virus antibodies are in the anterior chamber of these patients, in like 85% of the cases. And the last big outbreak of rubella in the US was in 63, 64, and the vaccine came out in 69. Are we now, after the vaccine, going to see Fuchs heterochromic iridocyclitis disappear if we're preventing people from getting rubella in the first place? Well, we're still seeing some cases. I don't think I see as many as I did earlier in my career, but we'll see. When choroidals develop after filtering surgery, why are they usually just nasal and temporal? You can see them elsewhere, but why do the vast majority of them form side to side? We don't know. What causes the anterior rotation of the ciliary body in plateau iris syndrome? This is not something you're born with. It develops over time. And if it's observed, some angles after you do an iridotomy, you still see a narrow angle. And if you push an indentation, you see a last roll. Watch out. 5-10 years later, it can keep rolling forward. There doesn't seem to be any inflammation in these eyes to explain why does the ciliary body keep rolling forward. Why is this much more common in the Middle East and in Asia, in the Chinese particularly? We don't know. Why does the cell loss in glaucoma respect the raphe? If the problem is blood flow behind or something happening at the disc, what is it about this tissue that is getting damaged and the one right next to it that has absolutely normal sensitivity? They're all being exposed to exactly the same pressure in the eye. What is it? They all have the same genetics. What is it that's causing this focal loss in glaucoma in eyes where elsewhere there may not be any loss at all? We think now that probably there's some kind of mitochondrial burnout, if you will, in many conditions that come on with older age. And any stress, like having a higher pressure in the eye, makes it harder for the exoplasmic flow to go through this area, may cause eyes then to have the glaucoma damage. And some people will be more susceptible than others. But why focally in the same eye? Real mystery. Love for one of you to figure it out and explain it while I'm still on the earth. Excuse me. Why do the trabecular meshwork cells become senescent in primary open-angle glaucoma? You can grow the cells from the trabecular meshwork from similarly aged patients and similar time from death to processing very easily in tissue culture, but not the ones from primary open-angle glaucoma. They are prematurely senescent, and like other senescent cells in the body, in the skin, and elsewhere, they begin to produce more chondroitin sulfate and less hyaluronic acid. And of course, their telomeres are running out. As you divide, you're getting less telomeres per cell, and but they get to senescence earlier. And this is what was found in the patients with primary open-angle glaucoma versus normals in these mass specimens that I sent to Paul Knepper and that we published in 1996. And so there's still work. Pigmentary glaucoma, the mechanism of ghost cell pigmentary and eye syndrome and modern gonius nucleolysis were worked out by Dave Campbell. Who's the new Dave Campbell is going to figure out these other problems that I've shown you? That would be nice to figure them out, and maybe, especially if they would give us better insight on what to do. Yes, one thing very quickly is, why did Dale Hoyer say that I am the Forrest Gump of ophthalmology? And I'm looking for the way of displaying all these slides at once so I can just point out a couple of them. And I don't see it, but at any rate, I'll just go way quickly through this. So one of the things that I did in my career is that when I was doing all that tissue culture work that failed, I realized that the early corneal transplant solution was stupid. They had bicarbonate as the buffer. You open the bottle, the pH would go to 10. So I put in Hempy's buffer, which is already understood, and I put in the color indicator because I knew that no ophthalmologist could be trusted to calibrate a pH meter. And it also helps you to see the tissue while you're sewing it. And in addition, if it becomes infected with bacteria, they'll usually produce products that are acid or base and change the color to yellow or purple, and you'll know not to use it. Also studied the reproducibility of the steroid response, and it's quite reproducible in people's eyes, but it has nothing to do with primary open-angle glaucoma. I did the natural history study of diabetic retinopathy in St. Louis that led to the diabetes control and complications trial, the part that was called primary prevention. And I was on its monitoring committee for 13 years, a kind of a ringer, a glaucoma specialist on a committee of retina and other specialists in diabetes. And one of the things I asked for when I was on that committee is what is the relationship between hemoglobin A1C and the rate of progression of diabetic retinopathy? And it turns out for every point lower you get on the hemoglobin A1C, you cut the risk of progression of retinopathy by 43%, and you increase the risk of hypoglycemic episodes by 33%. Now, that was information you might not have been able to use until recently when they have these patches to put on patients' arms that can measure for a month the level of blood sugar. So now you can aggressively go after lower blood sugars with lesser complications. So this tension between effectiveness of what you're doing and the risk has been changed by new technology. And I would say the same thing is happening in glaucoma. We can go for lower pressures because we have safer ways of getting there. And the safer your surgery becomes, the earlier you can use it in cases that are getting worse or already have moderate to severe damage. And we've tilted towards earlier action because the risk-benefit ratio has shifted, just as it has more recently in diabetes. And I guess one other thing to mention is that I picked for the residency program in St. Louis, David Meltzer, who had predicted pulsars and then went from physics into ophthalmology. And he saved the intraocular lens industry by finding polishing compounds on the surface of intraocular lenses that were causing the UGG syndrome. And excuse me, that particular cause was eliminated, excuse me, by doing ultrasound. And he was able to figure that out and was very beneficial. Excuse me, a lot of phlegm. I also, when I was on the study section, thought that this particular study was going to be important. Johanna Seddon wanted to look at lutein in the diet and also macular degeneration. And that really led to the ARIDS study. And I had to fight to get this approved because I saw, as somebody dual-wired biochemistry and medicine, that this might be an important insight. And indeed, Johanna Seddon was correct. And Al Summer wanted to do the Baltimore Eye Survey, and I had to really go to the mat for that one too, saying even though it's going to cost $2 million, we need to understand the epidemiology of glaucoma. And I added an automated perimeter to the study, which otherwise wouldn't have been done with one. So being dual wired, having training in two fields did end up having an influence on diabetic retinopathy, on corneal transplant media, and very peripherally, I've had effects in intraocular lens production and even understanding some things about macular degeneration. So I would just say, keep your mind open. Then we also saw this one patient who had a tumor, a lymphoma, that was treated successfully with Rituxan systemically, and then the tumor went away. And so the lymphatic lymphocytes of a lymphoma around the eye in both eyes was causing a bilateral glaucoma. We sampled on the first eye where we did surgery, we sampled the tissue, sent it out, and found out that indeed it was a lymphoma. And the treatment in the other eye wasn't another trabeculectomy, it was rituximab systemically, which solved the problem. So keep your mind open as you're looking at things, analyze problems, and hopefully you'll come up with better solutions than we even have now, and try to understand the mechanisms of what you are doing now so that you can do them optimally. Any last questions? See, we're a couple of minutes over, but any last comments?
No, doctor. I think we're good.
Okay, well, have wonderful careers. It's, you know, for all the things that are happening in medicine and in the world these days, there are wonderful opportunities out there. They'll be as good as they were in my lifetime. It'd be marvelous to see what new things will happen in the next 40 or 50 years. I've been in ophthalmology for 50 years, and it's been amazing. But now with genetics and monoclonal antibodies and all the things you have, sky's the limit. Love it. Enjoy it.
Thank you.
Thank you very much.
The
Thank you
patient
very much,
always-
Doctor.
the patient-
Thank you, Doctor.
Thank you. Bye-bye.